So next up, we have Chris Gallagher. He is the founder and president of Potomac Currents, and we're going to switch gears a little bit here and talk about a policymaker and decision-maker audience. Specifically, what are some of the successes and challenges in terms of sustaining and implementing and influencing effective obesity communications solutions in this space? So thank you, Chris.
Thank you, and I appreciate the Academies for letting me speak today about this important issue. Again, I'm Christopher Gallagher. I'm the Washington Policy Consultant for the American Society for Metabolic and Bariatric Surgery, the Obesity Action Coalition, the Obesity Medicine Association, and the Obesity Society. So I'm the one who usually takes up most of the time on calls, introducing myself and such. But I have been working in the healthcare environment for close to probably 30 years. And specifically, I've been working with the obesity community. How does this thing work? The big green one. Got it. Sorry. I've been working with the obesity community for the last 10 years, and we've made tremendous progress over the last decade in helping both federal and state policymakers better understand that obesity is a complex and chronic disease, and patients must have access to science-based treatment avenues across the care continuum. While we are making progress on this front, some might argue that it is only theoretical progress. For example, in 2013, TOS and ASMBS worked closely with OMA and endocrinology to shepherd landmark policy through the AMA's House of Delegates, recognizing obesity as a complex disease. The following year, this same coalition came together to expand on this policy to put AMA on record, supporting patient access to the full continuum of care of evidence-based obesity treatment modalities such as behavioral, pharmaceutical, psychosocial, nutritional, and surgical interventions. 3 years later, we got AMA to acknowledge the importance of using people-first language and encouraging healthcare providers to equip their healthcare facilities with proper-sized furniture, medical equipment, and gowns for patients with obesity, and having patients weighed respectfully. However, despite all these strong policy statements from organized medicine, health plans continue to practice their ingrained bad habits of denying coverage for obesity treatment based on the plan's belief that it's a lifestyle condition or that treatment is elective and solely for cosmetic purposes. That's why we went back to the AMA and argued that words and policy statements are not enough. We must work together and actively engage health plans to break down barriers to care. Last year, AMA adopted policy stating that it will work with state and specialty societies to identify states in which physicians are restricted from providing the current standard of care with regards to obesity treatment, and work with interested state medical societies and other stakeholders to remove out-of-date restrictions. In addition to organized medicine, we've seen a number of public and private health plans and state government associations recognize that prevention efforts alone are not working. Just like any other chronic disease, once a patient is diagnosed, they deserve access to science-based treatments under the same coverage guidelines and patient cost sharing enjoyed by others that suffer from chronic disease, such as diabetes, hypertension, or mental illness. Here are some of the groups that have stepped up. In 2014, the Office of Personnel Management put health plans that serve federal employees on notice that the agency will no longer tolerate plans excluding obesity treatment coverage on the basis that obesity is a lifestyle condition or that treatment is cosmetic. Not a mandate, but it is a strong message to health plans that they must provide a clinical rationale for excluding these services. 1 year later, the organization that represents legislators who chair insurance companies and state legislatures adopted its first ever disease-specific policy statement, urging Medicaid, state employee, and state health exchange plans to update their benefit structures to improve access to and coverage of obesity treatment, such as pharmacotherapy and bariatric surgery. And finally, last year, the National Lieutenant Governors Association went on record supporting efforts to reduce obesity stigma establish statewide obesity councils and task force, support additional training for current and future healthcare professionals, and support access to obesity treatment options for state employees and other publicly funded healthcare programs. Now, while all this is wonderful news, is it really having any impact on changing coverage policies? The answer is yes. Here are a handful of recent examples. In terms of bariatric surgery, health plans are starting to recognize that prior authorization requirements that mandate lengthy pre-op medical weight management programs are not supported by the scientific literature. Other plans are finally getting it, that bariatric surgery is in fact a preventive service in many cases, particularly for diabetes. In terms of pharmacotherapy, we have come a long way. At the beginning of the decade, we were helping FDA better understand that obesity needed to be treated seriously and that the agency must evaluate both the risks and benefits of new obesity treatments and focus more on obesity care as opposed to simply weight loss. As a result, we've seen 4 new drug approvals since 2012 and renewed investment in obesity care innovation. Another example of tangible progress came about in 2018 when the United States Pharmacopeia finalized a new independent drug classification system, which now includes a category for anti-obesity agents. This is a really big deal for us because USP developed this new system to address concerns from stakeholders that the current one, which was designed for the Medicare population, is now being used for developing drug formularies outside of Medicare, such as for state health exchange plans. This new anti-obesity drug class will hopefully preclude public and private health plans from excluding coverage. This is a major victory for TOS, OAC, ASMBS, OAM, and the Academy of Nutrition and Dietetics that make up the obesity care continuum, which first raised this issue in 2013. And in fact, we were kind of proud that USP staff mentioned us on a conference call a year before they released the classification, saying that we were kind of the catalyst behind them moving forward on it. Now, in looking at intensive behavioral therapy, we did a study a few years ago where we looked at state health exchange coverage for obesity screening and counseling, one of a number of preventive care services that are guaranteed under the Affordable Care Act. While we did find numerous examples of benefits for cholesterol, A1C, and STD screenings, we had a rough time locating any solid language that would lead the average person to believe that obesity screening or treatment was an option. In fact, 24 states had blanket exclusions for anything to do with obesity or weight loss and made no mention of obesity screening or counseling services under the preventive care services section of the plan. The remaining other states pretty much got a D- in terms of communicating that these, quote, guaranteed benefits to those in the state healthcare exchange. To address this inequity, the Bipartisan Policy Center developed the My Healthy Weight Pledge, the first ever collective initiative offering obesity prevention and treatment for individuals of all ages. These health plans and companies have pledged to work with providers and beneficiaries to increase utilization of these newly standardized benefits, ensuring that adults and children affected by obesity receive at least 12 intensive behavioral interventions every plan year. So it's a start. It's at the beginning of the range of what's needed according to USPSTF and Medicare, but it is a valuable first step. Now, I think the key to advocacy, as most everything in life, is trying. You've got to start. You have to be willing to take that first step and open a dialogue with a person and work hard on fostering that relationship. You need to build a strong base and grow your numbers, and most importantly, you need to train your people so you can help them help themselves. You need to join with others and demonstrate that there are many voices calling for change. Start your own band. That's what we did first off with the Obesity Care Continuum. Build your own coalition and don't be afraid to play with other bands. The most memorable events in history happen when multiple groups across the spectrum come together for one common goal. In terms of building your base, Here's a picture of the latest advocacy training session at the OAC's Your Weight Matters convention. Every year for the last 8 years, I hope I got that right, Joe Naglowski and Ted Kyle and myself, and joined by other leaders in OAC and industry partners, come together and train these folks through learning about federal and state policymakers and how things are done. And what you're seeing here is one of, I think, our unique efforts we do is role-playing exercises. We don't just sit and talk at you for hours and hours about, oh, this is policy, this is how it's done. We do that for maybe about an hour, but then we break into groups and spend about an hour and a half having you actually give your spiel to a, quote, mock policymaker or member of Congress, and you kind of get graded and, instructed and given tips on what you can do better in a positive way. And I think everybody who has done this program has truly enjoyed it. And what we're doing with these folks and others, we're deploying them out both, into D.C. and throughout their own states. This is one of the new programs that the Obesity Care Continuum has developed called the State Advocacy Representative Program, or STAR program. Now, the goal of the STAR program is to establish a cadre of multidisciplinary scouts at the state level to educate policymakers about the need for both prevention and treatment of obesity. Now, the STAR program is great because it enables us to kind of bring the issue of the need for obesity prevention and treatment to policymakers from a variety of different perspectives. And I've seen it work amazingly well. We had one example of the New York State Bariatric Surgeon chapter came down. They brought a nurse practitioner, they brought a PA, they brought a psychologist, they brought an obesity medicine specialist, they brought a patient. We had kind of everyone there to tell the story of why we need better access to obesity treatment. And it was fascinating to see the different perspectives that each person came and brought to each congressional meeting. And in terms of joining a bigger band, this is the Obesity Care Advocacy Network. The OCC, or Obesity Care Continuum, joined with the American Association of Clinical Endocrinologists, the Endocrine Society, and Novo Nordisk a few years ago in establishing the Obesity Care Advocacy Network. Now OCAN has grown to more than 20 organizations, and the idea is to kind of unite and coordinate with all the stakeholders in the healthcare community so we can elevate the message of the need for treating obesity seriously, both before federal, state policymakers, healthcare professionals, and patients. And finally, thanks, Patty.
Sorry.
Well, I'll end here. No, the biggest thing about this was, because when I was with the College of Surgeons, I first met the bariatric surgeons probably 1994 and 1995, and seriously, I think a lot of the colleagues in the surgical community did not look up to them and kind of said, well, they might not be they couldn't make it as general surgeons, and that's why they're bariatric surgeons. But as time has grown, bariatric surgeons have grown in stature, and people understand the need for treatment as they are starting to respect other obesity care providers. But I think the big thing I wanted to focus on, as I got sidetracked, but since I've been working with obesity in '94, I've always said we don't have anybody. We don't have anybody who stands up for us. You look at every other kind of, cancer and mental illness, you have a champion who stands up, who has a personal connection with it, and they push it through, be it, Domenici and Wellstone for mental illness, and celebrities like Glenn Close for schizophrenia. Cancer, you've got it everywhere. Stand up for cancer, during the baseball games. We haven't had anything like this that I remember. We have maybe someone who will chime in once, chime in twice, talk about healthy eating and such, and isn't that if this person can talk freely about, their struggle with their weight, that's good. But this was very personal, and went on the attack to go after Bill Maher for the stupid things he said. So I'm hoping that we can have more folks like James Corden stand up and take on, I think, bullies like Bill Maher. Thank you.